Good day, and we came to the last lesson in this series on assessment during labour and using the partograph. Now, just for a quick overview, we've looked at the whole total partograph, and then we have looked at certain parts of the partograph. For example, in lesson 1, we've done the fetal condition part. In lesson 2, the progress of labour part. In lesson 3, the contractions and the maternal condition. And then in lesson 4, we've looked at the 4 Ps. So in this lesson 5, we are going to do the interpretation of the partograph. Now, I think what I'm going to do first is we're going to interpret a normal partograph where labour progressed normally, and then we will look at a so-called abnormal or prolonged labour partograph. I am going to divide the lesson in 2 parts, otherwise the lesson is going to become very long. So we will call it the lesson 5A and a lesson 5B. In lesson 5A, we will interpret the normal partograph, and then in lesson 5B, we will do the abnormal partograph. Now, the objectives of this part, or to be able to interpret the partograph, is very important, is to interpret the recorded partograph, but also to recognize any deviations from normal, and then to describe the specific midwifery actions at the appropriate time, and to decide on a timely referral. And referral in this case means to call a doctor or to send the patient to a hospital if the patient is in a peripheral clinic or not in a hospital. Now, when we look at this, what we have here in front of us is the example of a so-called normal partograph, in the sense that labour progressed normally, the fetal condition was normal, etc. So what I'm going to do is I'm going to interpret every time span of this partograph, like as when you would do when you record on a partograph. So say, for example, you're the midwife who are doing the recordings on this partograph, and it's now 11 o'clock, and you are recording all these specific aspects that you have assessed the patient for, and then specifically using the 4 Ps, how do you interpret it? Then 3 o'clock, we will look at again what you recorded, how do you interpret it, and then we will also look at the partograph in general. And also, obviously, when we interpret the partograph, this is the maternal part of that same partograph, and we will use that in our interpretation as well. Same with the maternal side. So here, now unfortunately, and I apologize for it, there's a lot of information on the slide, so it's not always very clear. I hope that you will at least be able to see what has been recorded on the partograph. So what we have done is we've taken all the observations that have been done here at 11 o'clock on this side of the partograph and also on the maternal side of the partograph. And then we're going to come to our conclusions. So here you will see we have made the observations regarding the passenger. We've made the observations regarding the power passage in patient. So now if we look at the passenger, now the fetal heart is not really having anything to do with the progress of labour in the sense that the passenger influences that, but we need to look at the fetal heart, because if that's abnormal, obviously it will also determine how the patient is going to be dealt with. Now in this case, the fetal heart is normal. The fetal heart before contraction was just below 140 beats per minute, and after a contraction it was 140 beats per minute. So we see that there's no deceleration there. If we look at the presentation of the passenger, we can see here that it's a vertex presentation. If we look at the position, unfortunately there's not space on this partograph for the position of the fetus, but the position, as we've said, play a very important role. So if we do our assessment, we need to determine the position of the fetus, because in the case of the anterior position of the fetus, labor is more likely to progress normally, like in the or otherwise in the case of an occipital posterior position, we know that labor is usually prolonged a little bit, and there's also patient experience more pain. Now, in this case here, the membranes are still intact. We can see here it's been recorded as an eye, so the membranes are still intact. We don't know what the liquor looks like. If we look at the application of the fetus on the presenting part, we see that it's poor. So for some or other reason, which we will see now, is the fetal head, which is the presenting part in this case, as we've said, is not fitting very well on the cervix. And we have said previously in the previous lessons that the better the head is applied, or the better the presenting part is applied on the cervix, the better contractions we get, because we get this reflex reaction that good application on the cervix makes the a production of progesterone, which causes better contractions, and the labor progresses quicker. Now, we also need to determine the size of the baby. We don't know what the size of the baby is. Is the baby, when we palpate the patient, does it look like a normal size baby, or does it look like a very big baby? So we need to determine that. But when we look at these aspects of the passenger, it looks to us as if the passenger is normal, in inverted commas. The only problem here is that the application is poor. Then next, if we look now at the progress part of the partograph and we look at the passage, we see here that the cervix is 2 centimeters dilated. There's an X being made on 2 centimeters. There's a little circle being made at 4/5 above the pelvic brim. So we know that this head is still quite high. We see here, if we just move our glance a little bit further, we see that this patient is a graph 1 para 1. And we know, or we're supposed to know, that in case of primigravidas, engagement is supposed to start from 36 weeks pregnancy. And usually by the time that the patient is term, the engagement should be much further progress than 4/5 above the brim. So we see here that the head is quite high. And together with that, when we look at the descent, the station of the fetal head, we see here that it's -2. Molding is no molding yet. We see that there's the bladder is the maternal. When we look at the mother, there's 200 milliliters urine being passed. So that the bladder is not full, or we assume that the bladder is not full. We will see later on whether the mother is passing urine normally or not. The cervix and the vagina seems to be normal. So as far as the passage looks like, we are a little bit worried because of the head still being high, and that together with the application that's poor might be an indication. I think we will have get a red light here at the back of our brains to tell us we have to look out for this patient. Now, when we look at the powers, we see that she is having here 2 contractions in 10 minutes. That's between 20 and 40 seconds long. The frequency 22 and 10 minutes. Now the question is, remember when we did the contractions, we said we need to determine whether the contractions are adequate and effective. We're not 100% sure in this case whether the contractions are adequate or effective yet, because the patient is very early in labor. She's only 2 centimeters dilated. Now we see here that the patient is a graph 1 para 1, and as I've said, we know that there should be more engagement in the case of a primigravida. Vital signs are all normal, so we don't need to worry about that. The urine is all normal. There's no abnormalities in that. Hydration and ketosis seems to be normal because there's no ketones there. We're not 100% sure what pain she's experiencing, so we will need to find out about that. And now the question is, what are we going to do with this mother? What's our treatment and our management going to be with this mother when we see all these observations and where we are now? Now, when we look at all these observations that we have done here at 11 o'clock, it's now also very important to determine what our actions are going to be. How are we going to monitor nurse care for this patient further on? We all have said that for now everything seems to be normal, except that we are a little bit worried about this head that's still very high. The engagement is 4/5 above the pelvic brim and the descent is in the -2s. So we will do things like make the mother walk around. We will determine what the pain management, what we should try and do here. Pain is not contractions, are only 2 contractions in 10 minutes. So we kind of expect that she doesn't experience much pain, but we need to determine whether she can cope with the pain, even though we think that it's not bad. But so we need to determine that. We need to determine what pain medication or non-pharmacological pain measures we are going to give or do for her. There's no signs of ketoacidosis at the moment, but like we've seen on the next page of the maternal condition, but we need to give her some nutritious fluids and food so to prevent ketoacidosis. So we're going to make her walk around. We're going to help cope with the pain that she is experiencing at the moment, and we're also going to give her nutritious fluids and foods. Now, what is very important is that this patient is in the latent phase of labor still, as we can see here, and we give her 12 hours for a latent phase before we would be worried about, and before we would say that there is a prolonged latent phase. But then we see here at 3 o'clock, 4 hours later, she's now 5 centimeters dilated. So she's now in the active phase of labor. And this is now being transferred to the active phase of labor. And remember, we've said we take this from the latent phase to the active phase, and we record this cervical dilatation on where it crosses the alert line. So where 5 centimeters dilatation crossed the alert line, that's where we are going to make our cross here. And now we were going to see from here, I'm going to show you this part of the partograph and not this part of the partograph anymore, because we are here in active labor. So obviously we do exactly the same here. We transfer the latent phase recordings here to the active phase of labor, and we are just going to concentrate here on the active phase of labor. Now, if we look at all the assessments that's been done here at 3 o'clock, we have to look at all of it in relation to each other, according to the 4 Ps, and then again come to a conclusion and decide what we are going to do with this patient. Now again, when we look at the passenger, we see that the fetal heart is normal. The fetal heart rate there, now unfortunately you can't see the values here, which is a little bit frustrating, but again, as I've said, I apologize because my space is a little bit limited. But this is more or less 140 beats per minute before a contraction and about 135 after a contraction. So there's just a 5 beats per minute difference before the contraction and after the contraction. So it seems as if the fetal heart is normal. It's still a vertex presentation. We still don't know what the position is. We need to find out. It's important. But we also see now that the membranes have ruptured and that the liquor is clear. Now, what was very important the previous time that we've done our assessments, we have seen that the head was quite high. The head was 4/5 above the brim. So and the application is poor. So the one very important thing that we need to take now in consideration is the possibility of a prolapse of the cord, because the presenting part's not fitting well on the cervix, so that might be just a place for the cord to swim past, to swim through. So we need to look at that. Application, again, we will come to it also now when we come to the passage, is still poor, and we still don't know what the size of the baby is. When we look at the passage, now we see that the patient has made progress as far as the progress of labor is concerned. The cervix is now 5 centimeters dilated. There's a little bit of progress regarding the engagement of the fetal head as well. It's now 3/5 above the pelvic brim. The descent is now also a little bit better. It's -1 and not -2 anymore. There's no molding. She has passed urine now, 150 moles. 4 hours ago, she has passed 200 moles. So it's a little bit little for her, depending on how much fluid she has taken in here. So we really need to make a note, a mental note about the fact that the bladder might be full. And we must kind of encourage the patient to go to the toilet more often, to pass urine more often, or we'll have to make sure that the bladder is not full and become an obstruction to labor. So here we have still the engagement still a little bit high, but at least there's progress. The only thing that we're worried about here is still that the application is not very well. And we can see it to a certain extent to the contractions. There are 3 contractions in 10 minutes. They are still less than 40 seconds, between 20 and 40 seconds. So there's 3 blocks being colored by diagonal stripes. Now the question is, are they adequate and are they effective? The reason why I've said here query yes is because there is progress. The cervix has dilated more, and there's progress regarding the level of the head, if I can call it like that. So, and that's why I've said yes. We'll have to check now further on whether they stay adequate, whether the labor progresses further, etc. This patient is not receiving an induction or an augmentation. So if we look at the patient, everything seems to be normal here as well. The vital signs are normal. The urine, we see there's a plus protein now, but the blood pressure is still normal. So this protein might be from, we've seen that the membranes have ruptured now, so it might be the glycol that's in the urine that might make it protein positive. She's not receiving any medication yet. There's no signs of hydration and ketoacidosis. We still don't know anything about her pain experience. We need to find out about that. She's having more contractions now. The contractions might be a little bit longer. So I think that's definitely the one thing that we need to give attention to is, do the mother have pain? How's she coping with her pain? And then also, we don't know what's the position of the mother. Is she mobilizing? Is she lying flat in the bed? Is she lying on her back? Is she lying on her side? These are the things that we further need to determine when we plan our actions. But as far as the progress of labor is concerned, we're happy for now. There are some things that we are going to look out for, but for now, the most important things is pain relief. And I think if the patient can cope with the pain, non-pharmacological pain methods, the position of the mother, we can put her in different positions. We can mobilize her as best we can. Again, we can give her some nutritional fluids and foods because she uses a lot of her energy. We see that there's the one protein in the urine. Otherwise, it's still clear. There's no signs of ketoacidosis or dehydration. The maternal temperature is looks like 36, so there's also not an increased temperature. As we said, the vital signs are normal. Here's just a short summary of the care measures that we can implement during labor. And as I'm really saying, it's a short summary because there's just not enough time on this slide, on this specific lesson, to elaborate on the methods, care measures that we should do. The one very important thing that I haven't mentioned on the previous slide is also obviously patient education. Now we're here at 1700 hours, 1700 hours here. In the meanwhile, we have seen that the fetal heart's been recorded half hourly as it should be. The contractions are being recorded half hourly as it should be during the active phase of labor, and that seems to be normal. We've said that the progress of labor should be recorded every 2 hours. It has been done at 1500 hours. Now we're here at 1700 hours, and we look again at the same aspects: the passenger, the passage, the powers, etc. We look at the fetal heart is still normal. It's still a vertex presentation. We still don't know about the position and the attitude. Application now is good because we can see, and we come to that just here, is the engagement has now, there's a lot of progress in the engagement. The fetal head is now only 1/5 above the pelvic brim, and that makes that the head is now fitting so much better on the cervix, which makes the application good. So the engagement is much better, the dilatation is much better. We can see here that the patient is now 8 centimeters dilated, and she sits here on the left side of the alert line. She sits above, the cervical dilatation sits above the alert line. So we are happy. She's progressing. We've said she should dilate 1 centimeter per hour or faster, and we've seen that she has even dilated a little bit faster than 1 centimeter per hour. Her bladder she has passed another 300 milliliters of urine, so we're happy that the bladder is empty. But we see here something that is a little bit of concern, and that's molding, that there's 1+ molding now. Now molding, as we've said, might be a sign of cephalic pelvic disproportion, but what makes us a little bit less worried about the molding here is that there's good progress and that the head is not stuck somewhere. So we will just look at that very closely. The powers now, we see the duration is I apologize, this should be bigger than 40 seconds. We have now 5 solid blocks here. So we see that there are 5 contractions in 10 minutes. That's bigger than 40 seconds, longer than 40 seconds. Now we can definitely say that the contractions are adequate and effective because we can see how much labor has progressed. The head is going down into the pelvis, so obviously the contractions are doing their job. The patient, we see some problems here in the sense that the vital signs are normal, but we also see now ketones in the urine. So this is something that we need to check specifically up, because we have said that ketoacidosis might make that the contractions are not so effective anymore. It might also cause acidosis. So this is something in our care measures that we need to look at specifically. Now here we can also see that the patient has got pethidine and atarax for her pain. It's been recorded here. So we have decided that with 5 strong contractions, long contractions in 10 minutes, the patient really needs something more for her pain. And then we need to check on the position of the mother as well. Does she take in different positions? Is she moving around anymore, etc., to make sure that she is comfortable? And then when we come to at 2 hours later now, when we are again doing our progress, determining our progress of labor, we're coming at 1900 hours. Between 17 and 1900 hours, the fetal heart was still recorded half hourly before and after contractions, and it still looks normal. The contractions have also been done half hourly, and we still have 5 contractions in 10 minutes. That's longer than 40 seconds. Now I'm going to go briefly over this because now we see that this patient is now 10 centimeters dilated. She still progressed, the labor progressed normally. The cervix dilated 1 centimeter, at least 1 centimeter per hour. So it's still above the alert line, on the left side of the alert line. So we see that labor has progressed normally. The head is now 0/5 above the pelvic brim, so it's now fully engaged in the pelvis. The light core is still clear. Everything is normal, as we can see here, and we are very happy with what we see with our patient. Now, this is the end of this lesson 5A with the interpretation of the normal partograph. And as you can see how important it is to every single time that you record the observations to do an analysis of all 4 your P's, implement the nursing care according to that, and then in your next 2 hours you can see what the effect of that was.